Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Today's episode is sponsored by apnea. A few weeks ago, the AASM and the Obesity Medicine Association held a joint webinar exploring the use of tirzepatide for the treatment of obstructive sleep apnea. We wanted to follow up with our guests and review their recommendations, plus any new information or tips for sleep clinicians who may wish to add tirzepatide to their treatment options, just in case anyone missed the webinar. Dr. Radhika Breaden is a community sleep medicine physician and was board certified in obesity medicine in 2016. She is currently the medical director of Pacific Sleep Program, one of the largest independent sleep medicine practices in the Pacific Northwest. She's based in Portland, Oregon. Dr. Atul Malhotra is Vice Chair of Medicine for Research and Research Chief of Pulmonary, Critical Care, Sleep Medicine, and Physiology. He was the lead investigator for the SURMOUNT-OSA trial that was published in the New England Journal of Medicine. This led to the FDA approval of tirzepatide for the treatment of obstructive sleep apnea. He is a paid consultant for Lilly. Dr. Jeremy McConnell is board certified in family, sleep, and obesity medicine in private practice in Bradenton and Sarasota, Florida. He is a master fellow of the Obesity Medicine Association and board chair of the Florida Obesity Society. Dr. Rafael Sepulveda-Acosta is the founder and medical director of Sleep Fit Medical, Sleep and Weight Management Center in Sonoma, California. Board certified in sleep medicine and obesity medicine, he specializes in diagnosing and treating sleep disorders while addressing their connection to obesity and cardiometabolic health. He is an active volunteer with both the ASM Foundation and the Obesity Medicine Association. Welcome. I am really glad that you're all able to join us today.
Thank you.
Thank you.
Thank you for the invite, Seema.
Thank you.
So Atul is lead investigator in the SURMOUNT-OSA trial. Can you briefly describe the trial and the results?
Sure. Thank you for the invitation. Thank you for the opportunity. As you correctly disclosed, there's a conflict of interest in terms of Eli Lilly funded the trial, but I'm pretty hardcore academic, and so hopefully that'll come across. It was actually two different studies. SURMOUNT-OSA was study one, which were patients not on CPAP who couldn't or wouldn't use CPAP, randomized to tirzepatide or placebo. And study two were patients who were on CPAP who were randomized to tirzepatide or placebo. The primary outcome was the apnea-hypopnea index. For the study two, the CPAP patients, it was withdrawn for 1 week prior to the assessment just to see if the drug was doing anything as opposed to that the CPAP was working. So as many of you know, we did see a 50 to 60% improvement in the apnea-hypopnea index in both studies. And in isolation, that's interesting. But what became more compelling were the secondary outcomes. All of them were pre-specified. All were controlled for multiple comparisons. And so we saw major improvements in systolic blood pressure, about 8 or 9, up to 9.5 millimeters of mercury. We saw high sensitivity C-reactive protein, cardiovascular risk marker improve. We saw a body weight improvement of 18 to 20%. We saw the sleep apnea-specific hypoxic burden improve markedly as well. And we didn't just make the numbers look better, but the patients felt better. So the patient-reported outcomes, both daytime symptoms and nighttime symptoms, improved with tirzepatide versus placebo. So I think based on the strength of that study published in New England Journal a few months ago, the FDA approved tirzepatide for the treatment of moderate to severe sleep apnea in people with obesity on December 20th, I think, of 2024. So to me, it's an exciting time with a pharmacotherapy for OSA.
So was the improvement in AHI only due to weight reduction?
I get the question a lot, and I don't know. We published a meta-analysis about a year ago in Sleep Medicine looking at the change in body mass index versus the change in the apnea-hypopnea index. And if you look at the graph in that curve, the SURMOUNT-OSA result does fall in that curve, suggesting the improvement in the apnea-hypopnea index is attributable to the changes in body weight. But some of the whopping improvements we saw, like 9.5 millimeters of mercury, improvement in systolic blood pressure, I believe there may be off-target effects of the medications. And as a corollary, the FLOW study was in New England Journal about a year ago using semaglutide, which is a different drug, but similar. And in that study of chronic kidney patients that lost about 4 kilograms in 2 years, which is 9 pounds, not that much, but there was a mortality benefit. So many of us believe there are off-target effects of these medications that may be important.
And this is just moderate to severe sleep apnea, right?
Yeah, you have to have an AHI of 15 or greater to get into the study.
So, Radhika, do you think we should be board certified in obesity medicine in order to write these prescriptions?
No, I don't actually. One of the things in terms of getting the board certification is that in many states, you actually aren't even allowed to advertise that. The education around board certification is available to anyone on the Obesity Medical Association or Obesity Medicine Association, rather. And so I think some basic education on using this medication is appropriate for anyone who is prescribing. But I don't think you need to be board certified at all in order to use this tool effectively for our patients with moderate to severe sleep apnea.
That's wild that you can't advertise that.
It absolutely is a very big surprise for people who are board certified in obesity medicine.
Yeah, I never would have guessed.
Yes.
So Rafael has been doing this for a while. Do you have any tricks for what we need to document so that maybe we have a little bit more success with insurance approval?
So there's different steps to this. So first of all, I think during a consultation, make sure that we document the AHI that is 15 or above, consistent with moderate to severe sleep apnea. In the vital signs, measured baseline weight and height. And in terms of family history, document that there's no family or personal history of multiple endocrine neoplasia type 2 or type C or parafollicular thyroid cancer. Also document that there's, discussion of tirzepatide as an alternative of treatment for OSA, and the patient agreeing to pursue that as a treatment option. In terms of ICD-10 codes, use the moderate to severe OSA ICD-10 code, the G47.33. Make sure that you also add the obesity code, the E66.9, and the BMI code, which it's the C68.30 to 39 or the C68.41 to 45. In some cases, if you provide education as well, I use kind of the dietary counseling and surveillance, which is the C71.3. And during when you submit the prescription, make sure that the primary diagnosis is OSA, the G47.33. Also, during the process of sending that prior authorization, make sure that you send the report of the sleep testing, confirming the moderate to severe OSA diagnosis. And in some cases, you can create kind of a letter of medical necessity, just like we do for CPAP, for example, with the patient ID and date of birth, and just saying that the patient meets the criteria determined by the FDA for tirzepatide and OSA. And if there's any doubts, I always kind of ask the representative in specific cases or specific plans, depending on the state.
So does it have to be a fresh sleep study? Like if I had somebody that had moderate sleep apnea diagnosed like 5 years ago, would I have to retest them?
So most of the time, as long as the test is within a 6 months to 12 months period, they accept that. But that varies from insurance to insurance. So yeah, that's kind of what we have noticed here in our clinic.
That's interesting, right? So then you have to navigate sort of the CPAP carryover effect, the retest.
Yep.
Because then if they have too much carryover effect, right, it may bump them from moderate to mild.
That's right.
So a lot of things to consider then. So
Definitely.
if I want to start doing this, Jeremy, do you think I should get baseline labs, or how do I sort of dive into this?
So I think it depends on the perspective of the physician. Really.
Okay.
There are two ways to look at this. The first is from the standards that are established in the obesity medicine space. It's routine to order a standard lab panel with any patient who's starting or embarking upon a weight management program. And so typically that might be What I do is a CBC and a CMP, TSH, lipid panel, an A1C, just essentially for anyone who's starting into our program. Now, the second part of that question really pertains to tirzepatide itself,
Right.
and whether or not there are any indicated labs specifically for the use of tirzepatide. And in terms of the label for Zepbound, there aren't any recommended labs for initiation. The one caveat to that, which may play a role, tirzepatide not only reduces appetite drive to eat food, it also reduces thirst drive. So in
Oh.
our patients who perhaps have chronic kidney disease, or they may be a little bit perhaps prone toward dehydration, they could experience, and there's an increased risk for acute kidney injury in individuals that's thought to be due to volume depletion. When you look at the side effects of this medication being largely gastrointestinal in nature, such as nausea, that could attenuate PO fluid intake. And so some patients may be a little bit sensitive to that. And in the trials with the class of medicines, individuals that start with some degree of CKD may be more prone to acute on chronic problems. So knowing creatinine clearance and GFR may be useful in patients who may be at risk for that.
Oh, that's interesting. I didn't realize that about the thirst.
Yeah, it's interesting. We've seen this across the entire class that some patients just, they just, in a manner of speaking, they just forget to drink.
Wow.
And then they'll go, 8, 10, 12 hours, and then they'll find themselves, having some orthostasis maybe. And,
Oh
and
my
just,
gosh.
yeah. And,
Wow.
and so it can happen. So it's certainly one of the primary things that we try to educate patients on is they have to maintain good hydration and good nutrition.
Radhika, is that what you do too with your labs?
Yeah, exactly as Jeremy mentioned. It's really those primary baseline labs that we would do for anyone embarking on any kind of weight loss evaluation. So it's not necessarily because it's tirzepatide, but because we'd want to have those baselines. And then, following, to make sure that, again, with the hydration and making sure that we're not, missing anything over time in terms of kidney function or anything like that.
What if someone has been like adopted and you don't have a family history of like MEN2 or something like that? How do you navigate that?
I'll address that. In my experience, I think in my 25 years of practicing medicine, I don't think I've seen any patients who have either MEN2 or MTC.
Oh, wow.
That doesn't mean that they're not out there, of course, but having treated lots of people for obesity and using these agents for years now, this class of drugs, it's just not something that we clinically see all that often. And so if a patient does not know or they don't have any reliable family history to go by, I don't let that be a barrier.
So I can add a little bit if I may. I'm married to an academic endocrinologist, and we had that discussion a couple of days ago, actually.
Oh, okay.
She does see MEN too, and she does see medullary thyroid carcinoma. The concern with GLP-1s is a theoretical one. So in animal models, you can see MTC, whatnot, but in humans, it's not. She said the concern is theoretical, and she used a stronger word, but I'll say bogus.
I think bogus should be part of our medical vernacular. I like it. So let's take a short break, and when we come back, we'll talk more about the use of tirzepatide for obstructive sleep apnea. You're listening to Talking Sleep from the American Academy of Sleep Medicine.
Dive deeper into the future of sleep apnea therapy with the Apria Sleep Care program. Once we receive the PAP referral, our team springs into action, offering patients a seamless transition into therapy. Patients start by selecting how they want to begin their sleep journey: in-person care, virtual care, or self-directed care. With ongoing therapy support, including coaching, digital resources, and video assistance, we're committed to ensuring every patient's success. We stay connected with our patients with live calls, texts, emails, and IVR, all designed to make adherence a breeze. And with our supply schedule program, replacements are delivered like clockwork. Experience the difference of an enhanced sleep therapy program with Apria Healthcare. Discover more about our innovative sleep program online today at apria.com.
Welcome back to Talking Sleep. We're talking with our recent webinar guests on how to incorporate tirzepatide into your obstructive sleep apnea treatment options. So then, after we've initiated treatment, how should we be following our patients? Is this sort of the same cadence as CPAP follow-up, or is it different?
Well, if I may, one of the key components of the use of this medication is that the dose titration schedule is somewhat protracted. We're looking at starting at 2.5 milligrams for 4 consecutive weeks, and then going up to 5, and then up to 7.5, 10, et cetera. And that process can take quite some time. Treatment emergent side effects are more common with dose initiation or initiation of
Okay.
therapy, and also with dose escalation. So having some degree or a plan to monitor those patients during that first 4 to 5 months is certainly relevant. And so I think that it's appropriate. And what we do in our practice is we see those patients back on a monthly basis
You
for those dose
do.
adjustments.
Radhika, is that what you do too?
In the beginning, exactly.
Mm.
Yes. And then, what we have found actually is that since the FDA approval has occurred, we have many patients who were stable on tirzepatide, so to speak, or on a particular dose, who have now been getting it under the indication of OSA, and so they're needing less frequent follow-up. They have a particular dose that they are on, so they're not new starts. So it's individualized. It depends on if they're a new start for tirzepatide or if they're if they've already been on the medication.
So is it that you keep them on the lowest effective dose, or do you just go every 4 weeks and increase it if they're tolerating it?
So the way the trials were done was with the maximum tolerated dose.
Okay.
It's called the MTD. And so they were escalated in the SURMOUNT trials to either 10 or 15 milligrams was where most of them end up.
Is it okay to kind of leave them? Like, let's say somebody is losing weight on 5. Can you leave them there, or will that effect wear off?
That's not how the trials are done, but there's clinical judgment involved. In my experience, and the data suggest that the nausea, vomiting, diarrhea, constipation seen in about 25% of patients attenuates over time. So by 1 year, we saw almost no GI side effects reported, and very, very few patients dropped out because of side effects. And so there's habituation to those side effects. So in general, you can escalate the dose over time, and that's how the trials were done.
Mm. Is that your clinical experience too?
I think there are 2 different philosophies, at least in the obesity medicine space, on the use of this medication in terms of dosing, which are relevant. I think the first is to titrate to the maximum tolerated dose.
Okay.
We know that weight loss results are better at the higher dose ranges. So if you look at the SURMOUNT-1, SURMOUNT-2 trial, and those that achieved the higher dose ranges had a greater effect from a treatment standpoint. And in treating obesity, we sort of have a runway of time during which, because everybody will plateau out on their weight loss at some point in time, as metabolic adaptation sets in and as the body has countermeasures to prevent ongoing weight loss. So there's a timeline in which we, in essence, want to strike while the iron is hot, right? While the patient has high motivation. On the other hand, we're oftentimes struggling against either side effect profile or adverse events, or medication coverage, cost,
Right.
and availability. So many others might take the philosophy of using the lowest effective dose,
Mm.
as you mentioned, Seema, and that's a great strategy. I just think again it goes back to individualization, and some of these factors that might play a role on dosing structure.
Because I hear from patients, right? I don't want to be on this forever. I don't want to be sort of
Right.
quote unquote hooked on this, right? And so I think there's this, for some people, they want to do the lowest dose possible. And I wonder if it's because they think that maybe the rebound weight gain then, once they're off of it, might be less. I don't know if there's any logic to that.
I can add a couple of things if I may. So
Yeah.
the SURMOUNT-4 study was a randomized withdrawal study. So they gave people tirzepatide and they lost weight, and then they randomized them to get either tirzepatide or placebo. So when they stopped the tirzepatide and gave placebo, the weight came back, and it's a function of how much weight you lost is how much weight you regain. So about 90% were back to baseline weight at 1 year. And so there is a rebound effect when you stop the medication. The other point, though, they'll make is if you look at head-to-head comparisons about Tirzepatide versus semaglutide, for example, there was a New England paper a couple of years ago that showed better glycemic control with Tirzepatide, but there was debate about whether the semaglutide was adequately dosed. It was 1 milligram dose. People go to higher doses. So I think when you start limiting the dose of these medications, it may limit the efficacy as well. And, that's a trade-off and clinical judgment thing. As I said, trials are done with maximum tolerated dose with Tirzepatide. There's another trial that's in press, I think, at New England Journal, the SURMOUNT-5 study. They went head-to-head Tirzepatide and semaglutide at the maximum tolerated doses, and Tirzepatide still won. But that's how it was 21% versus 13% or something for weight loss. But suffice it to say, maximum tolerated dose is how it was done. If you decide clinically to do it differently, that's up to you.
90% rebound, though?
If you stop the drug, 90% rebound.
Wow. Because that's what I always wonder, right? Their BMI normalizes, and then do they qualify for the medication, or do we just sort of sentence them then to gain it all back again?
Well, I'll say a couple things about that. There are lots of efforts ongoing with all these different companies to try and come up with either skeletal muscle agents to try and preserve basal metabolic rate after you lost weight. Diet and exercise, these things are very important. I've seen clinically patients who take up sports and things and can maintain weight loss. There's oral agents like orforglipron that are in the pipeline to sustain weight loss. But yeah, just starting and stopping the drug is not ideal. So ideally it is kind of long-term treatment.
Radhika, what are your thoughts?
That's exactly what we counsel patients on. And I think that's been one of the questions that patients have, because we do say that this is expected to be a lifelong drug because of that SURMOUNT-4 data. And some of those questions about whether it is going to be covered, once they are, at their goal weight, and, all of those other questions that we have regarding those long-term, effects, long-term coverage, weight regain are, having patients look more clearly at what their overall motivations are. If their motivation is for obstructive sleep apnea alone, and they're comparing it head to head with CPAP and other treatment options, versus are they looking at weight loss as a global risk factor for them for reducing the risk of diabetes and cardiovascular disease, and looking at weight loss for other health reasons as well. So that's part of the counseling that we do.
So I'm kind of wondering, you had brought something up about how we document, right? Like we'll say residual HI is like 2 on CPAP. So would you do the same thing and say, I guess you would have to retest them at their goal weight, I'm guessing. And then would you document AHI of 4 on Tirzepatide?
Yeah, I think you're asking an important question there, and that is, sustainability of the insurance coverage. I have seen clinically some patients who were obese and then lost a bunch of weight with the meds, and then insurance says you no longer qualify. They stop them, and the weight comes back, which is pretty stupid. But that's how medicine works sometimes. So I agree. It is a bit like if you give somebody CPAP for sleep apnea and their AHI resolves, you don't then say they're cured and they don't need CPAP anymore. So I think it is a matter of documentation, but if the only indication is BMI, then I think you're a bit vulnerable when the BMI is fine.
BMI and then moderate to severe too, right? For sleep apnea.
Yeah, but I think once that's documented, I wouldn't revisit it like that. So.
Well, that's what I'm wondering. Like, is it standard practice then, like we would do with bariatric surgery, to retest them once they're at their goal weight? Or now, because it's not just discontinuing PAP therapy, right? Now, potentially this is going to affect their ability to receive this medication.
Yeah, so a couple points there. In the SURMOUNT-OSA study, there were 30 or 40% of patients, up to 50%, depending on definitions, whose sleep apnea was in remission. That was defined as either an HI less than 5, where you really wouldn't continue CPAP, or an HI between 5 and 15 without symptoms. And so up to 50% you'd put in remission. But I actually don't agree with that necessarily. I think there's lots of reasons we treat mild sleep apnea with an HI between 5 and 15.
Yeah.
Epworth score is one of them, but blood pressure might be another, fatigue might be another, non-restorative sleep may be another. So I think that is, to me, an individualized decision, not based on a number. So, but if you say 30% are in remission, I think it's a fair thing to retest them and see if they still need CPAP at that point. But the point I want to get across here is that, you don't treat either sleep apnea or obesity, you treat both. And I think the data on that is really clear.
Which is kind of where you live, Rafael. You do both of these all the time. So what are your thoughts about retesting?
So I usually retest when there's at least a 10% of total body weight loss in different increments. I always reinforce patients that the remission is not guaranteed despite that weight loss. And once we have results of sleep testing, if there's a decrease in severity, we basically consider all the alternatives of treatment. I mean, there's patients that want to continue on their CPAP and they're doing well symptomatically. There's patients that decide to go in with a mandibular advancement device. And also in terms of the tirzepatide, in terms of, once they reach their goal weight, I discuss with them if they, want to continue tirzepatide, as long as they're maintaining their weight, consider, if they want to de-escalate their dose and kind of monitor their weight with what they're doing in terms of lifestyle changes. If we should bridge with other anti-obesity medications for maintenance. And obviously all of this is with close vigilance with lifestyle modification strategies.
So I'm wondering if there have been any new developments since we chatted about this when we did the webinar a few weeks ago.
The New England Journal a couple of days ago had the Yastropov long-term follow-up from SURMOUNT-1. So that was the initial study with tirzepatide looking at weight loss. I think they saw like 21% weight loss. What they published just now is a 3-year follow-up from that, where if I remember correctly, the odds ratio for incident diabetes was like 0.07, like a 93% reduction in incident diabetes. So it's basically, if you're on the drug, the new onset diabetes is basically zero. So
that's exciting news.
It is, isn't it?
Absolutely.
Definitely.
I think the biggest challenge we face in sleep medicine today, with the shortage of sleep specialists and a great deal of backlog of work in a lot of our practices, is how do we accommodate this demand? And as Atul said, all of the other pharmaceuticals that are in the pipeline and say in phase 2 and phase 3 clinical trials for obesity right now have OSA treatment arms included. So the day is probably going to come when this isn't the only agent that's going to be on label for treating OSA. I would fully expect that, if we're not seeing it already, we'll have droves of patients wanting to get sleep tested. How ironic is that? Right? So they can have access to this wonderful therapy, right? But where do we go from there? Because in my practice we have 7 providers, and for sleep we see about 2,000 visits a month.
Holy smokes.
In our obesity clinic, one provider can only handle about 300 patients.
Yeah.
And we're having 20 to 25 what I call Zepbound talks a day. Right?
Holy
That doesn't mean all
smokes.
these patients start on drug. It just means that the people are coming in and they're inquiring about it. So you can imagine how our systems could actually be very, very quickly overwhelmed with a population of patients who require more involved management than what we're used to from a sleep medicine perspective. So it's a very interesting dilemma. And with other agents coming down the pipeline, we'll see probably more of this rather than less of it in the years to come.
Well, and it really just kind of hits at something that Atul talks about a lot, that our current model isn't great. This is not going to serve huge amounts of people, right? And we need to be, creative and think about how can we deliver, excellent clinical care in a more streamlined manner that really centers the patient, right? And serves the patient better.
Yeah, that's true. And I think it's also a concern too. I am concerned about patients who maybe don't see a sleep medicine provider, who might order a test and then use that as a key to initiate something like Zepbound, which is wonderful for that patient. Don't get me wrong.
Mm.
But what if they have moderate to severe OSA? Certainly, and are they going to go a year without treatment before they achieve the possibility of disease resolution? And furthermore, even though the disease resolution was rather strong, there's still, if you do the inverse, still half of the patients still
Right.
have residual clinical disease that would require treatment. So I'm a little concerned about that comprehensive approach and where that's going to go.
Yeah, I mean, you're right. I think we need to have a seat at the table.
Without a doubt. Without a doubt.
Definitely.
There's a point of emphasis there, and that is in the study design, we never went head to head with CPAP. It was never Tirzepatide versus CPAP.
Mm.
So to say it's better or worse than CPAP was not the goal. The goal was not to take down CPAP. It was to say Tirzepatide was better than placebo in either patients not on CPAP or those who are on CPAP. So I think the first line treatment, the standard of care, is still CPAP.
Still
And,
CPAP, yeah.
you know,
Yeah.
the idea that you could ignore the underlying cause of the sleep apnea obesity was probably not very clever on our part as a field. But the analogy is, as a pulmonologist, is if you're treating emphysema and you ignore smoking, you're probably not
Right.
a very good doctor. And so I think you treat both.
Yeah. No, that's true. And it's funny because I guess I'd never considered just doing Tirzepatide alone and not treating the sleep apnea, sort of like short term, right? Treat the sleep apnea with oral appliance or CPAP or whatever as we work on weight reduction with Tirzepatide.
That's right.
Right.
It's a continuous,
Yeah.
dynamic, both inclusive kind of process.
Exactly.
2025 marks the 50th anniversary of the AASM. Here is Dr. Sonia Ankoli Israel talking about the contributions of women in both sleep research and the advancement of clinical sleep medicine.
I think that one of the most important for me as a woman in the field of sleep medicine, one of the important things that I see now that I'm so proud of is how many other women there are. We started out as a minority, right? As in many fields, and now there are so many women. I mean, we have wonderful men in the field too, but we've always had wonderful men in the field. So now have women who are impactful in their own right and who are doing wonderful research and are being recognized for the work that they're doing. I feel like we've now become equal with the men, which is so important. And so I'm very proud in whatever small role I may have played in helping that happen as a early female in the field. It's something we can all be very proud of.
Now back to our conversation. As a private practice physician, I don't have a clue how I would incorporate this into my current workflow and our current clinic staff. To me, it seems like this is kind of a heavy lift, and there are a lot of moving parts. I collaborate with our local obesity clinics, but I'm not really sure that we have that fine-tuned yet. So what advice do you have for me and my colleagues who are in private practice practicing sleep medicine?
Well, I would say that first of all, having that partnership, I think, is a great first step. So I think you've already gone there, and I think having that communication is absolutely key. I think having the education of the SURMOUNT-OSA study results with your patients, as you know, that discussion is very important. The patients know about it, they read about it, it's all over the news. And so making sure that you have your educational tools, built as easily as possible for your clinic. I know we've discussed in the past, I have a slew of smart phrases and smart tools, so that onslaught of my chart messages that I received, get responded to with 2 clicks with a summary saying, thanks, I'm glad you're discussing this. Here's a summary of the study. Please make an appointment if you wish to discuss it. And that weeds out a lot of the people who say have mild sleep apnea, or who didn't realize that, the medication might need to be taken long term or things like that. So, some basic educational tools can be very helpful. And then, making sure that your staff gets some in-service on the process if you are prescribing within your clinic. So, there are tools, there are, desktop, pens, models and things like that. So
Oh, yeah, that's a good idea.
yeah, so as much as as much as each clinic wants to integrate this, there are these tools, there are in-services that Lilly performs. In the beginning, we had a medical liaison give a 1-hour talk to all of our providers about the SURMOUNT-OSA data. I think this was back last September. And they were very happy to arrange that. And we could ask questions. We could, ask a lot of questions about study design and data and all of those things, so that every provider felt, whether they had board certified in obesity or not, obesity medicine or not, they could really get their questions answered and feel very confident in making sure that they understood the data and could speak about it knowledgeably to the patients. So I think creating your tools, creating your workflows, having those liaisons in the community are all really important for any private practice in sleep medicine, because this is one of our new major tools that we have.
Mhm. Also, I agree with Dr. Breaden, creating a kind of a partnership with primary care providers and other specialists like endocrinologists and cardiologists, very, very important to implement some weight management treatment in conjunction. Also, educating staff is extremely important, I believe, so they can identify when there's, an adverse effects that needs immediate attention versus something that, it's mostly education for the patient. And integrating advanced practice practitioners, advanced nurse practitioners, and even registered dietitians within your network in the patient care, so we can educate the patient better. And using chronic care management tools such as portals or telemedicine to educate patients on their treatment.
Jeremy, did you have thoughts?
One of the things that I'm seeing in the obesity medicine community in particular is there's a lot of questions that they have about, okay, how do we diagnose sleep apnea? How do we get our patients?
Yeah.
I would say that in my work with the Obesity Medicine Association and mentoring practices on this, there is very little, well, there's a deficit of just tangible knowledge and practical knowledge on how to go about that right now. And they are looking to us because they need us. And so that's, I think, an exciting thing for our practices today. However, on the converse, we also need them, right?
Right.
So one of the things that I think sleep medicine providers can do is either go to the American Board of Obesity Medicine website, where they can put in their zip code and they can find who is ABOM certified in their community. They can also go to the Obesity Medicine Association or the Obesity Society's directory and find clinicians in their community to collaborate with. And I think that's really important. We want to recommend that our colleagues are following evidence-based clinical practices, and we really want to identify who those people are in our communities who do that and do it well, and find ways to collaborate with them, especially toward the treatment of this intersection of OSA and obesity. And if one feels compelled to go get the education to do it, great. I mean, there's some great introductory continuing education courses offered by both the Obesity Society as well as the Obesity Medicine Association, which are very time efficient. I have all of my providers go through that education. My sleep providers, I had them go through the obesity education so they can become more familiar with it. And so there's ways for people to embark upon this if they want to. And it's very rewarding.
And from what I understand, you can sit for obesity medicine boards without doing a fellowship, right?
That's correct. It's not an it's not an American Society of Medical Specialties recognized specialty.
Oh,
So there is no
okay.
requirement for fellowship at this time. Most of the fellowship programs that are out there right now are really more academic focused.
Okay.
And so for most people who sit for the boards are, if you will, on the job training and continuing education and real world practical experience.
Oh, is that why you can't advertise it?
It's because it's not an ABMS. Yeah, it's because it's not an American Board of Medical Specialties board.
That's right.
And so
Oh.
most states will say that you cannot they will only recognize ABMS boards.
Okay. All right. I connected the dots finally. So what about if I have somebody who is already on like Ozempic or Wegovy? Is there enough of a difference to switch to Tirzepatide?
Yeah, that's a really good question. So following with what Atul said, if we know that the magnitude of BMI reduction translates to AHI reduction, I would look at it as, which is the better agent? And if a patient has access to either one, my preference would be for Tirzepatide,
Huh.
because I think the results are better. Plus, we also have the data to go along with that. That being said, if we have a patient who is on an agent such as Wegovy, and they've had weight reduction and maybe they really plateaued out, we probably ought to, at that point, make a reassessment or an assessment of their severity of OSA so we can give them guided treatment as to what modification might be necessary at that point in time.
That's a good point about the plateau. Okay.
Well, then we've seen some folks at that point in time, they may still qualify for bariatric surgery. Let's say they went from a BMI of 45 to say 36, and they're not continuing to lose anymore, and they still have significant obesity with comorbid risk factors. They may still at that point in time be a candidate for weight loss surgery. So sometimes the treatment plan will modify according to, where they are, where they've come from, and what the current indications are at their current state.
So what is the math? Like how much of an improvement in AHI should I expect per like percentage of weight loss?
So I can address that, and I already disclosed my conflict, but it is worth making the point that Tirzepatide works through slightly different mechanisms. It's a GLP-1 receptor agonist with GIP. So that's glucagon-like peptide 1 with GIP, which is either gastric inhibitory peptide or glucose-dependent insulinotropic polypeptide, which is a mouthful, I realize. Semaglutide or Ozempic is GLP-1. So they're working through slightly different mechanisms. If the only goal is weight loss, then you could argue, it doesn't matter how you achieve a given amount of weight loss. But as I said, head-to-head, Tirzepatide seems better than semaglutide for glycemic control from that New England paper, or perhaps the semaglutide wasn't dosed adequately. But then that paper in Press, the SURMOUNT-5, where Tirzepatide looks to be superior in terms of weight loss. How much weight loss is enough? There's a fair amount of scatter in our meta-analyses. When we look at 20% weight loss, which is what we achieved roughly in SURMOUNT-OSA, that's about a 50 to 55% reduction in the apnea-hypopnea index. Arguably, you might want more than that, but to get more than 20% is ambitious. There are newer drugs in the pipeline. There's one called retatrutide, which is GLP-1 with GIP with a glucagon agonist, and that we're involved in studies as we speak where we're potentially going to have even more weight loss than with GLP-1 GIP. There was a retatrutide paper in New England Journal, 2 years ago now, and they have ongoing studies including with sleep apnea.
So is that the math then? 50% reduction in AHI with 20% weight reduction?
Well, as I say, there's a fair amount of scatter. So I don't, every patient's different. So I see some patients where there's a threshold. If they get below a certain level, sleep apnea is resolved. I'm told it's the same with type 2 diabetes as well. There's some that have a threshold. Some it's more of a dose response. There's a lot of discussion about whether that curve is linear or curvilinear or quadratic. And there's a whole, when we published that thing, there's a lot of bickering about how to fit the curve. We're doing analyses now with SURMOUNT-OSA to look at changes in BMI versus changes in AHI. And I can't release those yet, but more to come.
So any final thoughts, Rafael?
Yeah, I mean, I think one of the things that I always tell kind of my colleagues is, don't be afraid to pursue the Tirzepatide as a treatment for OSA and obesity. With practice, we kind of learn along the way. Also, creating realistic expectations ahead of time with the patient, with measured goals and indications and expected treatment longevity. And that way, with that communication, you can achieve a better outcome.
Radhika, any take-homes for us?
I would agree with exactly what Rafael said, and I would just also encourage anybody who doesn't know where to start to go to the Obesity Medicine Association and sign up for one of their webinars on obesity medications and on tirzepatide, and just understand the mechanism of these medications, understand the basics on how to prescribe, how to manage, and then contact, your Lilly representative for medical liaison talk, and, kind of get your hands dirty and get in there. And, it's, we've done a lot. We feel very comfortable with CPAP management. We can do this too. And it just takes a little getting used to, but those resources are out there and widely available.
Atul, what about you? Any takeaway points for us?
Just real quick, there's 3 pillars of health: diet, exercise, and sleep. If you ignore one, the other 2 will suffer. That hasn't changed. It's an exciting time for our field because we have a new drug treatment for sleep apnea, which is great. But I don't see as therapies in competition. There's about 1 billion people out there with obstructive sleep apnea, as we have estimated. That number is increasing, not decreasing. So there's plenty of, all boats are going to rise here. So there's plenty of patients who need help and need treatment. Again, you treat the whole patient, not just the sleep apnea, not just the obesity, the whole patient. And you already know that, but it's worth hearing the cliche sometimes.
How about you, Jeremy? Any take home or final thoughts for us?
I think that the message I would probably convey to our colleagues is that your work is important, your work is needed. We have to address this. As a specialist in both sleep and obesity, but also as a person who has obesity and sleep apnea, myself, our patients need us to learn these things. And we need to kind of lean in. Don't be afraid of it, as was said earlier. This is an exciting time. We have some great tools that we can use to help our patients. So I'd encourage you to get in the water. It's good.
Well, thank you all for joining us today and guiding us on the use of tirzepatide in our sleep medicine practices.
Thank you very much.
Thank you.
Thank you.
Thanks.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.